Talking about management of renal trauma, there is a lot that was developed in the new guidelines, and we are talking about management, but are we still making progress? Are we still using the same approach that we used before? So what's new and what we can improve? So if we consider overall renal trauma incidence, it's low. It's about 1%. But when abdominal trauma is associated, then it can goes up to 24% of the patients will have renal injuries associated with it. When we look to the renal trauma divided by mechanism of injury, blunt makes the majority of the trauma mechanism, and penetrating traumas is only about 20%. And if you look in where you're seeing those patients, it increases a little bit if you're in level 1 trauma center compared to the level 2 or level 3, that you don't see those patients more often. And when we see the trauma grades at the presentation of these patients, usually they are low grade. So in the blunt renal trauma in the adult population, we see the majority of these injuries related to the motor vehicle accidents. But in PIDs, we can see that the cause of injury is more distributed in falls and auto-PID also. So it's important to think about the mechanism of injury and your patient age before you try to decide what we're gonna do. And also, when we are looking for penetrating injuries in large centers, we are looking more for gunshot wounds. And that's very important when we think about the anatomy. Like if you have a gunshot wound, it's more devastating compared to a stab wound because the energy of the trauma and the organs that are related to the kidney, we can see that the kidney is very well protected in the abdominal cavity and surrounded by important structures. So for the gunshot wounds, we also have to think about the associated injuries before addressing the kidney injury alone. When we are consulted by the emergency room doctors or from our colleagues, general surgeon, we always have some short history, and it's always like that. Hey, I have here a renal trauma, I want you to take a look. But before you go there and take a look, it's very important to know what the history was, what the trauma mechanism was involved, the anatomy, possible associated injuries. So think about before you step in the room or you go there and make any decision. Like if you have hematuria out of proportion, think about other anatomical abnormalities that might be involved in these patients. And also about the initial management. What was done for this patient before you get involved? So we're gonna go back to the basics. We trust our emergency room doctors, we trust our surgeons, but was that all done correctly? Was this patient seen here or is being transferred from another center for us to treat? So go back to the basics, do your ABC evaluation, make sure you have the lines, the catheters in place. Be careful when you're interpreting labs. Like we know that dipstick can have 3 to 10% false negative rates for hematuria, and that can, you probably can rule out a trauma based on a wrong exam. The images you have, we're gonna talk a little bit further. Are these images appropriate? What do you need before make a decision? So don't jump to your conclusion and management before you do your full assessment. And then you're gonna decide, am I gonna operate on this patient or can I do conservative management? So again, important to know a little bit the history about a patient, know if there is any associated anatomical abnormality if possible. Take a look in previous images if it's a known patient from your institution, and consider the previous anatomical abnormalities before you make your decision. It can change your decision making. When to image those patients. So again, The AUA guidelines mention trauma mechanism. It's broad. So when you shoot image based on trauma mechanism, think about the energy. Consider other lesions in these patients. Consider the other persons involved in the accident, how bad they are. Ask, if you have the opportunity, how was the car, how was the vehicle, so you can have an idea of the injury, you can have an idea of the energy. So AUA also recommends imaging patients with gross hematuria. All of them should get image studies. Patients with low systolic blood pressure and microscopic hematuria, they should get imaging, and this has like a grade B recommendation. But clinical decision, when we think about other injuries and mechanism of trauma, we don't have enough evidence to support, it's just grade C. But for me, it's one of the most important part of your evaluation. And CT IVP, we're gonna talk when we're gonna classify these patients. It's a very important tool, but to now, we don't have good studies to support it with grade A evidence. So what are the options? What can we use for imaging? Ultrasound is not accurate to evaluate the initial imaging. We can see if there is perirenal hematoma, we can see if there is probably a renal laceration, but we cannot evaluate the full extent of the lesion. IVP and single shot IVP, we don't do that anymore. It's only when it's your only resource available. The MRI is not commonly used. It can be used in patients with contrast allergy, but it's time consuming, expensive, and it's not gonna give you a lot of information, additional information compared to the CT scan. Nuclear scan, same thing, takes time, and you're not gonna have the same clarity of the anatomical details and also other organ injuries that you would have with the CT scan. So then the AUA guidelines recommends that we should perform CT IVP with IV contrast with immediate and delay images. And why the delay images? It's very important for us to classify these renal injuries. But are we following the recommendations? So this group from Utah, they did this study where they evaluate if we were compliant with the AUA guidelines. So they identified 126 patients with either grade 4 or 5 renal injuries, 126 patients with high-grade renal injuries, and 102 had either grade 4 or 5 or renal injuries with perinephric fluid collection. An initial delay image was performed in only 73% of these patients. And then when you look at collect system injuries that was initially diagnosed, it goes down only to 19%. And we were missing 33% of the time, we were missing the late phase, and we were missing associated injuries that led to 43% delayed treatment for these patients. So if we don't do the late phase, if we don't do the CT IVP, we're gonna miss important lesions, and almost half of the time it will delay surgical management of these patients. So most of the time we get involved, it was already done a CT scan by gen surgeons. So it's important to talk with your emergency department, teach them and tell them why do you need the late phases. It's not gonna add a lot of time. It's not gonna change too much the patient management in the initial treatment. If he was stable enough to go down to the CT scan, he can probably wait 10 more minutes and get a fast scan again. And the IVP give us a lot of information, especially for the classification. Like when we are talking about low-grade renal injuries, grade 1, grade 2, or grade 3, it doesn't make that difference because we are talking about stable patients, small lacerations with small perifluid perirenal collection. But the grade 3 and grade 4, how do I know if that collection in the grade 3 one with the arrows is the same thing that I'm seeing here with the grade 4 and contrast stabilization. So I really need the delayed phase. And when we are talking about grade 4, there is a lot of authors suggesting that we should substratify the grade 4s. And Dr. Morey did an update on the renal trauma classification for the grade 4s, dividing in vascular, parenchymal, and collecting system. But we still classifying these patients based on the AAST that is back from 1989. It gave us a lot of information. We put all of us in the same page for research, but it doesn't affect our management. So I think it's time to think about where we want to be and what the answers we need from the classification to help us managing. So the shortest, the simplest the classification is, easier for us to communicate, easier for other doctors involved in the care to understand when we need to be involved and when we need to take these patients to the operating room. So when intervention is recommended. So when you look for patients with signs of bleeding, but they are unstable, you're gonna make your choice. Does he need to go to the OR right now, or can I do something that could be less invasive and potentially save this kidney? So consider IR always. If you have a good team, consider embolization, because when we're talking about instability, it's not that patient that is in shock and crushing in front of you. This patient is already in the operating room with general surgeon. We are talking about those patients with tachycardia. We are talking about the patients with slow bleeding and decrease on the hemoglobin over a certain amount of time. So we have time to take these patients to the IR suite and do embolization. When we are called during the exploration and we see expanding and pulsatile hematoma, that's probably the only time we're gonna be explorating these patients, and we don't know what we're gonna jump into it. If the patient was not imaged before because of his instability, very likely if we open that hematoma, we're gonna end up doing a nephrectomy. And also, before you explore, think about that the cava and the aorta is right there. So if that's a penetrating injury, that hematoma might be only due to the kidney. So you're gonna explore zone 1 and zone 2 at the same time. If we have arterial injury on the CT scan, and that's like a solitary kidney or it's bilateral embolization, super rare, but it's something that we want to intervene right away to save renal function. And in more late on the care, large urinoma that is not resolving with conservative management, that's a patient that we should benefit from drainage. And the conservative management, we don't have a clear workup that we should do. We don't have a clear guideline to follow those patients, but we're gonna have to decide if the pain, if the ileus that is not going away, or it's that use of analgesics, it's the other injuries associated with it, like bowel contusion, liver lacerations, rib fractures, pneumonia. So all these changes in labs, changing patients' clinical vital signs, or even fever, are those coming from the kidney or from other organs? All major traumas can cause all this without being the renal injury alone. So the management of the blunt trauma, most of the time for grade 1, 2, and 3, we can treat them conservatively. We don't need to rush into take these patients to the operating room or tell the family that we're gonna need to explore. Most of these patients will do fine with just observation. And the challenging thing on the management of these patients is to calm down your ICU team and your general surgeons. They will call you all the time saying like, hey, hemoglobin is dropping. It was 8 yesterday, now it's 7. Okay, calm down. This is something that might be hemodilution. Let's take a look. It's not bleeding severely, what we can do. For the high-grade renal traumas, the grade 4 and grade 5, if those patients are stable, most of the time we don't need to do anything right away. So we can still go with conservative management, and maybe this patient need a later intervention, but nothing that we have to do right away. We know that if we rush into exploration, this is associated with high rates of nephrectomy. Urinary extravasation, most of the time you can manage with time and a Foley. Even if you have parenchymal rupture that is going into the collecting system, like a grade 4, if you decompress your urinary system, these patients will heal fine. And just look for the alarming signs: fever, pain that is not improving. These patients, you're gonna have a low trigger to re-image and maybe re-intervene. For the penetrating injury, is a little bit more different, even though we can still do a lot of conservative management. If it's a posterior, if the penetrating site is posterior to the anterior axillary line, 89% will not need any intervention. So we can observe these patients safely if there is no other associated organ injury. If the projectile is low velocity, you can still observe. And if we see patients with penetrating injuries that are stable at your evaluation, 40% can be managed without surgery, and 50% on the stab wound can be managed without any intervention. So these are reassuring that half of the time we are not going to do anything for these patients. So what can predict intervention? So how to prepare or how to monitor the patients that are high risk for intervention. So Dr. Wessels externally validated this paper that they showed that intravascular contrast extravasation was one predictor for intervention associated with medial laceration of the renal parenchyma, and when you have a hematoma that is large, like larger than 3.5 centimeters. Transfusion of 2 or more red blood cells units was 25% more likely to receive intervention, but we have to be cautious interpreting this data. Adequate resuscitation of these patients needs to be done, and this is changing and changing a lot. So in the past, we used to give crystalloids for these patients and fill them up with saline, 2 liters, and then if not responding, 2 more liters. We know that colloid and crystalloid resuscitation alone can worsen the bleeding. And that we have now this massive transfusion protocol for trauma, where we use the thromboelastogram or TAG, or the ROTEM, the thromboelastometer, which is pretty much measuring the blood elasticity. With that, Dr. Moore put this massive resuscitation protocol where the patients come unstable or and penetrating injury, they get a fast. If they have severe injury, like documented in more than one body region, they activate the massive transfusion protocol. With that, these patients get right away blood and plasma. After that, you reassess your patient. And then you're gonna monitor these patients on the TAG. And the TAG will determine what kind of blood product you need to give. So you're not just giving them red blood cells, you're targeting the coagulation cascade down. So instead of just giving crystalloid, now you're gonna target exactly where the bleeding is. And with that, they showed to decrease mortality in multi-trauma patients. So if we are evaluating a patient with bleeding, we're gonna take a look in that if that's done correctly. Endovascular embolization is one of the interventions that we're gonna do more frequently, and it's pretty much for patients that we cannot stop the bleeding clinically, those patients that keep having persistent decrease in the hemoglobin. Patients with arteriovenous fistula or pseudoaneurysm and gross hematuria, this is something that we're going to see a little bit later on, like a few days after the initial trauma. And if those patients that the bleeding cannot be stopped, but we got to be cautious with the massive transfusion protocol. And intervention goals is pretty much control the bleeding, repair the kidney when possible, and perirenal drainage if you have a collecting system injury that is not improving or getting worse clinically. And here is just to see that if you intervene immediately, you're gonna have a high rate of nephrectomy. So be cautious and go for conservative management when possible. So be aware of the resuscitation and be involved on that. Sometimes when you have arterial injuries, you can revascularize these kidneys, just stenting the artery when possible. So here's just showing that you can revascularize this, just putting a stent, and third day's imagings show the renal parenchyma well perfused. The indications for exploration, we covered all that, is only when conservative treatment fails. So be cautious, go slow, and just treat those who is not improving.